Good evening, everybody. Good afternoon, maybe good morning, depending on where and when you are joining us. We are very happy with such a turnout for today's webinar. So the topic of today is lifelong LUTs and inuresis in adolescents. And we have two specialists with us, which we're also very happy with. So welcome Dr. Mauro van den Ende and Professor Lynn Dosche. Just before we start, some practical information that this webinar will be recorded and will be made available for ICCS members afterwards. So if you are not a member, you can join us by going to the website and joining. I am Bieke and I will be the moderator today. So first we are going to start with a presentation from Dr. van den Ende, and afterwards we're going to have the presentation of Lynn Dosche. If you have any questions, you can put them in the chat, and afterwards we're going to take some time to try to answer as much of your questions as possible. So first I want to present you our first speaker, which is Dr. Mauro van den Ende. He's a urology resident at the University Hospital of Ghent, and he's combining clinical work with a PhD about the transition of pediatric to adult urology. And he's presenting now his PhD research to us. So Mauro, very welcome to you. Thank you for being here, and the floor is yours. You can share your screen and give us your presentation.
Okay. Good evening, everybody. I hope everybody can see my screen. If not, please interrupt me. First of all, I would like to thank the organization for the opportunity to present my PhD research on the topic of lifelong LUTs. And I want to thank Bieke for the kind introduction as well. So I will be talking about lifelong LUTs, how we call it a matter of transition. And I want to start off right away with what we consider to be lifelong LUTs. For us, that is more a terminology that we like to use based on this graph that has been published in 2023 in Neurourology and Urodynamics by our research group, where you see that we consider LUTs to be a functional unit of complaints that fluctuate throughout the lifespan, and that you really have to look at the level of clinical perception of LUTs of the individual patient when looking at the severity of the symptoms. I think the first important thing to compare with this terminology that's often used, and that's chronic. We don't really believe chronic to be very suitable for LUTs, as it is quite rigid in focusing on a time indication and not really focusing on the individual themselves. Chronic is also considered to be of a minimal duration of 3 months and has a slow progression, and we don't really believe that LUTs fits that box. Therefore, lifelong, it's a combination of life, focusing on the person, the patient itself, with the individual complaints and their perception to it, and long estimates the duration of the symptoms. We believe lifelong LUTs should focus on the impact that it has on the individual, merely than the terminology that has been used. By calling it lifelong LUTs, we acknowledge the dynamic nature of LUTs throughout the lifespan, and surely the influence of different transition phases that it has on it, talking about puberty, menopause, and elderly. And as Bieke already introduced, my PhD research is mainly focusing on puberty, so the transition phase from pediatric to young adult urology services. The first thing that comes to mind when talking about this transition phase is, I think, terminology. I try to summarize a little bit what is the recent update of the ICCS classifications of LUTs. And I think it's a very nice update already, but what happens when patients transition from pediatric services to adult services is that different terminology is sometimes used for their complaints. And we experience the patients themselves to have some difficulty in really understanding what terminology fits what box. And I think it's important to take it into account when comparing those age groups. Then this slide is merely to summarize the link that we all already think know, the link between pediatric symptoms as nocturnal enuresis and nocturia in adult groups, and that there is a clear link, as you see in the overlapping predisposing factors. There are differences for sure, like sleep arousal disorders are more often with nocturnal enuresis, and global polyuria more in adult groups. But we clearly believe that there is a link, so that transition from these age groups to one another is important. When talking about refractory or persistent nocturnal enuresis, or more LUTs, specifically in the adolescent and young adult group, it is still often considered a childhood condition, to be benign, to resolve spontaneously. But we know now already that it persists. And even in severe cases, only 50 to 60% has a resolution rate of their symptoms. And overall prevalence of lower urinary tract dysfunction is estimated or reported to be 9.3% in teenagers. I think an important introductional slide as well is a way of looking at incontinence as a trajectory, as has been published in this publication, based on the British ALSPAC cohort, where it is important to distinguish different symptoms and categorize it more into bedwetting alone, daytime wetting alone, or persistent wetting, which has both. And what I think is interesting here is that when you look at the different trajectories, it has a different persisting of different symptoms at 14 years old, was beautifully shown in the study. For example, daytime wetting as a child resulted in 10-fold more daytime wetting at 14-year-old, and persistent wetting into 23-fold more bedwetting at 14 years old as well. I think this indicates beautifully how you have to look at the individual trajectory of every child and take it into account when they go into transition to young adult services. So this was what was the hypothesis of my PhD research as well, is what is the pathway in between LUTs or nocturnal enuresis as a child into nocturia or LUTs in adult groups? Does it have to be something, does it have to do with daytime symptoms as a child, with nighttime, or both? And this quote from Petrangeli, published in 2014 already, highlight the importance of prospective trials such as the ALSPAC cohort to examine really what happens during the developmental years and how some symptoms persist into adulthood in some of our patients. Then what in my research we actually already discussed. It has been published in a review of our expert meeting at the ICCS in 2024, where we established 3 different pathophysiological mechanisms, potentially explaining the transition from pediatric to adult care during puberty. One of those is the psychological pathway, which we think needs to incorporate adverse childhood experiences, early puberty, which results in low self-esteem in certain teenagers. There is many literature about that, and concomitant affective symptoms that has a bidirectional relationship with LUTs in pediatric population, but also in the adult population. I think I don't need to go over all the adverse childhood experiences that there are, but these are the ones most commonly reported in literature, with the 3 highlighted ones to have a more prominent effect on depressive symptoms, suicidal attempts at later age. What has been shown in the ALSPAC cohort is that adverse childhood experiences from birth to 8 years old increase the odds of LUTs at age of 14. A 1-unit increase in the A score was also associated with an increase in the odds of any urinary incontinence. And girls who experienced stressful life events were at a greater risk of new onset urinary incontinence. I think this beautifully shows that there is a pathway from ACEs to LUTs in teenage years and even later, both for persisting symptoms that already exist, but also new onset symptoms. What we then did in a review was look at how the bidirectional relationship of affective symptoms such as anxiety and depression may be related to lower urinary tract dysfunction and OAB, both in younger patients as in adult patients. And what we hypothesized, or what we concluded, is that it's really reliable as well on the individual's vulnerability and resilience to adversities, and that it has an effect on their functional disorders. This is based on a 3-hit model published by Lua in 2017, where there are three elements that can influence the severity of their symptoms and how they cope with it, being genetic predisposition, early life environment, and later life environment. So it's things to consider when you assess a patient who has both affective symptoms and LUTs that keep persisting, that this may be important. We also established negative health beliefs, cognitive coping strategies, and personality traits to increase stress sensitivity of our patients, and increases also the severity of how they perceived their functional disorders, being lower urinary tract dysfunction. And early adversities already have been shown to be a mediator to cope with their symptoms and coincide with affective symptoms and LUTs. This also has been shown, I think it adds very well, is that delayed development of bladder control was prospectively linked in also an ALSPAC study to poorer self-image, negative school perceptions, and peer relationship problems. And that resulted then again in persistent wetting in those teenagers, which I think shows beautifully the importance of this mechanism. And daytime wetting and voiding postponement in mid-adolescents were strongly associated with mental health problems at age 18. Going to the second pathophysiological mechanism that we highlighted is a genitourinary maturation, where we look at pubertal timing and the interplay between brain, bladder, and kidney. So we all know these pubertal indicators. We have age at peak height velocity, age at menarche, and tenor staging system. And what we actually hypothesize is that an early puberty, for example, or an altered pubertal timing then considered normal. We all know that normal is not really a terminology we can use, but that a variability in this timing can result in a disruption in hormonal balance and therefore result in urinary tract maturation alterations. Specifically looking at the different organs then, in females, we know a rise in estrogen leads to pelvic floor muscle strength and a maturation of bladder lining. And in males, a rise in testosterone leads to prostate growth and urinary flow influence. Therefore, if one of those balances is altered, we hypothesize as well that this influences LUT symptoms, but also the persistence of those symptoms existing as a child already. From kidney, I think Lien Dosche will talk about this even more in depth, but we know that there are different alterations influencing diuresis and nocturnal enuresis from kidney perspective. We know in puberty that adolescents have different circadian rhythm alterations linked to their internal clock that changes, but also very coinciding with lifestyle changes, being laid up at night, an altered sleep rhythm, and that results in a different diuresis pattern as well, influencing or even potentially aggravating their LUT symptoms. We know that inadequate nighttime AVP secretion also influences this during the night and could increase nighttime symptoms or bedwetting. And we also need to look at comorbidities like obesity. That is a major problem in our teenage group right now. And an altered dietary and salt intake resulting in altered kidney filtration and therefore also having an effect on their LUTs symptoms. Then looking at brain, during puberty, we know that the hypothalamic pituitary gonadal and adrenal axis are altered or reorganized, and this therefore also influencing the hormonal balance that these children have as a child. And as already was discussed now, this can have an influence on their urinary flow and their LUTs as well. We know during puberty that a decrease in melatonin happens as well, which coincides with sleep disturbances that are also often in these age groups. And augmented exposure to blue light, for example, also alters this and therefore has an influence on their sleep patterns, but also on their nighttime LUTs. Then going to the third pathophysiological mechanism that we highlighted is looking at circulating levels of IL-6 and TNFR2 and the role of the microbiome. What has been shown in literature now already is elevated cytokines in urge incontinence and OAB contribute to earlier age at menarche in girls. That has been shown. And there is a link between early age at menarche and circulating IL-6 or TNFR2. And that makes me go as well to a very, very important and interesting study published as well on the ALSPAC cohort that looked at the causal interplay between ACEs and LUTs and the mediating effect of IL-6 and CRP. What there has been shown is that higher levels of IL-C were associated with odds of urinary incontinence, daytime wetting, and nocturia at age 14, and that associations between ACE scores and urinary incontinence, daytime wetting, and frequency were mediated by IL-6, which highlights the possible inflammatory mechanism or aggravating ACE symptoms that already augment a certain stress level, therefore aggravating the OAB or urgency complaints that these children can have. We also performed a systematic review looking at the microbiome. This was specifically in children. We looked at alterations in the urinary and gut microbiome in pediatric LUTs and UTIs. But what we saw and was very interesting was sex-specific differences post-puberty. In females, the urine microbiome composition changed until puberty and then afterwards stabilized if you compared it to adult samples, and those of males remained stable. This has multiple possible explanations like anatomical differences and changes such as the length of the urethra, so that those things we know. But the fact that it changes after until puberty and then stabilizes in females makes us think as well, is there a developmental factor influencing this? An important limitation of this, and something we could not stratify, was the use of antibiotics possibly interfering with this microbiome. But this is a question you can ask the patients as well. How many antibiotics did you use if you're thinking about the microbiome as a potential cause for persisting LUTs? So trying to summarize, I think there are different pathways we can look at. The psychological pathway certainly plays a role, looking at adverse childhood experiences and affective symptoms coinciding with LUTs. We have pubertal timing having also a hypothesized influence on the persisting of LUTs, and inflammation has also been shown, quite preliminary yet, but is promising to look at this. So what could we conclude already is, for the transition from pediatric to adult services, we need a structured program looking at all different factors potentially influencing their persisting symptoms. We need to look at it multidisciplinary and in a holistic way, looking at all different elements that could contribute to these persisting symptoms. We already asked us the question as well, what is the cost of thinking about LUTs in a lifelong perspective and specific transition period? We performed a systematic review where we looked at different age groups, but sadly, the main gap was the cost of LUTs in infants and children. So this highlights the importance of looking at this as well, and incorporating this when you're trying to set up a transition program, which is something we are trying to do as well. And I think one of the most important questions we should ask ourselves, we can look at this from a healthcare professional's perspective, but what are the current experiences and barriers of patients going through that transition phase? And this is where we introduced our own study now. That's the Streamway study, a study of transition in real life experiences affecting micturition and well-being in adolescent years. This is a mixed method study where we included teenagers, young adults from 16 to 25-year-olds who have functional persisting LUT symptoms from childhood age, and we want to go in a conversation with them. We want to invite them for a semi-structured interview to ask them, how did you experience the transition from pediatric to adult services? What things were good, what things were bad. But if you did not experience something like this as a transition, what did you miss, or what could have been better? We also want them to create a urological timeline from birth until the moment that they are included in our study, so to have in that way somewhat of an indication of the costs that came already. So they need to complete all their doctor visits, hospitalizations, operations in that timeline, together with a parent or guardian, of course, because otherwise they would not be able to collect this themselves. And we ask them as well to fill in a questionnaire at the moment of the interview on how their symptoms are at that moment of time. So this is something that we're currently doing. Patient enrollment is still ongoing, but the results already look promising, and I hope to be able to present them very soon. Yeah, I think this sums up my presentation, and if I'm understood correctly, we do the questions afterwards, but I hope it was already something interesting. I personally already found it during this research. Thank you.
So thank you, Dr. Van den Ende, for this very interesting topic. We're immediately going to go to our second speaker, which is Professor Lynn Dosche. So Dr. Dosche is a pediatric nephrologist, also at the Ghent University Hospital, and both in her clinical work as in research, she is very interested and passionate about bladder dysfunction and enuresis in children, and she's going to talk to us about bedwetting in teenagers. So Dr. Dosche, I give you the word.
Okay, so I hope you can see my slides. So good evening, everyone. Thank you for joining, and also thank you to the ICCS to invite me to give this talk. So before we start, I hope I can move my slides. No. Okay, yeah. So I have nothing to declare except that I am a pediatric nephrologist and not a urologist, so I hope I don't disappoint anyone. And my surgical skills are really best kept out of any operating room. So that's for that. And also tonight's session isn't really about the cutting edge evidence either, because frankly, the research on adolescent enuresis is still scarce. So I'm very happy that with the group of Mauro and his colleagues are changing something about that. But that's exactly why we need to talk about this topic tonight. So let's begin with this comic strip. It illustrates George Orwell's own experience, the famous writer, with bedwetting in a strict English boarding school. So if you try to imagine that you are waking up as a child or a teenager in this case in wet sheets, you feel ashamed, you're confused, and you're also not knowing how to stop it. And that's actually the reality for many children, but also for adolescents sometimes. So our key question for tonight is, how do we approach bedwetting in teenagers? How can we help them? So, and why is this topic relevant? Well, adolescence is a transitional stage. It's physically, psychologically, and socially a very important phase, as Mauro also already showed us. So adolescents lower urinary tract symptoms, including the bedwetting. It presents unique diagnostic, but also therapeutic challenges. And this is largely because these teenagers fall between our pediatric and our adult functional urology departments. And also there are no really standardized management protocols that are specific for the adolescent enuresis. If you look at ICCS guidelines, they always mention children and adolescents together, that the guideline is for both, but maybe we need more specific protocols for this group. And therefore, our clinical care remains sometimes suboptimal. So the research in this area is also too limited, from my personal belief. So we really need to do better, because also in some, the persistent childhood onset symptoms are overlooked and they keep suffering from these symptoms. So to improve our care, we need better protocols, we need more research, and we need some structured transition pathways to ensure that these patients are not lost between the two services, pediatric and adults. Because it does have an important impact on these teenagers. It's not just an inconvenience. It can be dramatically distressing and can have profound psychosocial consequences, as already also was shown. These teenagers, they often feel embarrassed, they have anxiety, sometimes even avoidance of social activities, such as sleepovers, but also development of relationships and sexual activity can be impaired. So research, as you also saw, the numbers shows that they really score higher on the social anxiety measures compared to peers. And also many of them worry about their future relationships, and this leads to secrecy around the condition. So the impact on their self-esteem is really significant, but it can also have an impact on their family dynamics, because parents may feel guilt and frustration and losing also their own confidence in their parenting skills when it fails, while the children are struggling also with their own self-confidence, with making friends, and even academic performances. So for some, when these effects persist into adulthood, further influencing their holidays, their overnight stays, their intimate relationships. So clearly the consequences are really far-reaching and they demand greater clinical attention. So the epidemiological data is also rather scarce, but the numbers that we have show us that it becomes less common with age, but it can persist into adolescence, and then it does not disappear overnight. The expected spontaneous cure rate, but there's a really old study, but they estimate it should be around 15% per year. But we see that the severe cases rarely resolve without any medical help. So we see around 5% of the 10-year-olds still wet the bed, and there is an estimation that around, and one study that was performed in China, that 2% of the 19 years old still experience bedwetting. So we estimate around 0.5% of adults still suffer from enuresis. But we really need more good epidemiological data, and we have now this recent cohort that Mauro also already presented to you. So the differences in enuresis between children and adolescents is that adolescence, as already mentioned, it's a stage in life where there is a lot of development. Enuresis, it may persist from childhood, but it can also present as a new onset problem. And we see that with age, there is an increasing tendency towards more severe enuresis, as you can see on the graph. The older they get, the more number of average wet nights per week they show. So the hormonal changes, evolving sleep patterns, but also lifestyle habits like staying up late with the blue lighted screens, caffeine, sometimes alcohol consummation, they all influence our bladder control and nighttime urine production, and they can all have an effect. So these differences highlight why adolescents' enuresis requires tailored approaches rather than just simply extending our pediatric protocols. So when we look at classification, these clear definitions are really also essential. So we have good ones from the ICCS, for example, making comparison between primary and secondary enuresis, where in the primary enuresis we have patients that never achieved consistent nighttime dryness, while our patients with secondary enuresis, they had already for at least 6 months dryness and then have, for example, a relapse or a new onset problem. Next, we also know the classification between the monosymptomatic ones and the non-monosymptomatic ones, where in the non-monosymptomatic ones, there are also daytime lower urinary tract symptoms present. But the severity matters too, and so the episodes can be sporadic or occur every night, and they may or may not include daytime symptoms, and it can also change during time. So you have good periods, bad periods. It's quite typical that you see some evolution also in the same patients. And then, to end with the onset, as already mentioned, we don't have clear numbers, but I think a lot of the cases are persistent childhood enuresis cases or relapsing childhood cases, but there are definitely also new onset cases that we need to be aware of. So unfortunately, so we are still lacking a clear classification for our adolescents. So we are here with our pediatric definitions or with adult definitions, but it would be really interesting if we would have a specific set for adolescents as well. So the pathophysiology for enuresis, well, we all know it's a multifactorial problem. We also know the highly cited typical tree system model, where the importance of the brain, the bladder, and the kidney is shown in the past, that they all three systems can be involved and have an influence on each other. But besides this classic simplistic tree model approach, we also need to take in account genetics. There are more and more interesting findings in that area as well. And we often also hear positive family histories. And then it can be interesting when you have a child or adolescent with enuresis to also not only ask about enuresis in the family, but also, for example, ask parents if they have nocturia problems, because you would be surprised if you start asking them how many families actually think nocturia is something normal because the parents suffer from it themselves without even knowing it's actually a condition. And also another important issue is increasing rates of obesity in our childhood and adolescent patients. Polyphagy, polydipsy can also lead to imbalanced glucose metabolism, can lead to glucosuria and higher salt excretion that has its influence on the nocturnal urine production. And another very important side effect of being obese can be that you develop an obstructive sleep apnea that is also already in many studies shown that has an influence on enuresis and nocturnal urine production at nighttime. So this complexity explains why our treatment often requires a tailored multidisciplinary approach. And then, of course, we also have comorbidities. So comorbidities are a bit the same as in our childhood population. It's also very important to look for signs of constipation and or fecal incontinence. In many of our patients, when we screen for them or ask about it, we see neurodivergent of neurodevelopmental disorders, for example, ADHD or ASS. Also psychological issues, where it's sometimes the question, is it is it the start or the consequence of suffering from enuresis? Sleeping disorders can also be an important comorbidity, and as already mentioned, obstructive sleep apnea. It can be in obese patients, but also in not obese patients, it can be an issue and have influence. So impact of puberty. The puberty, it introduces, it is, as already mentioned, profound psychological and behavioral changes. It can all influence our enuresis. We see a rise of our sex hormones, the estrogen and testosterone, and they can affect our pelvic floor tone, but also the urinary flow. And also renal maturation can also alter the circadian control of our urine production. And at the same time, we also have hypothalamic pituitary remodeling happening in the brain that can also impact our vasopressin secretion during the nighttime, and also, of course, sleep quality, creating a new dynamic neuroendocrine environment that can also have an impact on enuresis. So circadian rhythms, they shift. And as already mentioned, also lifestyle factors, so as already mentioned, late nights can shift this. So it can all complicate also our management. We also need to take into account this different lifestyle. And also when we start a conversation about behavioral treatment in these patients, we need to take those things in account. And saying this, it's also very important that these adolescents need a different approach than when we see a child often together with the parents for incontinence problems. In puberty, this can shift that you, for example, see the patients without the parents. They also want to take often more ownership of their condition and their treatments. You also want them to take up more responsibilities, especially when it comes to therapy adherence. So you really need to take these things into account when you go into communication with these teenagers. And as already mentioned, therapy adherence. Of course, you still need to remember that they, even if they want more ownership, they still need support as well. So family encouragement, and also still have attention for the parents as well is also important to help the overcoming challenges that comes with this. So when assessing a teenager with bedwetting, I would say we can start with the same principles as in our younger children. It's always very important to start with a detailed history taking, using the screenings lists that are also available from the ICCS. And of course, a good clinical exam is also very important. We also suggest to do a urine sample, for example, to screen for glucosuria or for urinary tract infections. I would also still recommend using a good bladder diary to have an idea about the volume of the voids, but also the drinking habits in these patients. And then you can add on, if you have it available, uroflowmetry and ultrasound to see if there's any signs of post-void residual urine to have an idea about their voiding habits. This is still non-invasive uroflowmetry, so if you have it available, it can be a very interesting thing to do. And then from a treatment aspect, I think also the managing bedwetting in the teenagers should have a stepwise approach, just as we do in our child population with enuresis. So I would also start with the basis, so with behavioral support. For example, limit the fluid intake before bedtime and also try to avoid drinks that can be irritative for the bladder. Of course, also support voiding or even double voiding before bedtime. And then the two strategies most used to treat enuresis are of course the alarm therapy and medication, so the desmopressin. So the bedwetting alarms, they help conditioning waking up at the start of urination. And if you have a motivated teenager and that can use it very consistent, it can be a very good starting point to treat. The desmopressin is often used in patients that show nocturnal polyuria because it can reduce our nighttime urine production. It can rather work quickly, but we see quite some relapse rates when we stop the medication. And also you need to take into account that around 1/3 up to half of the patient doesn't have a full response to desmopressin. So sometimes we also use a combination therapy of both alarm and behavioral support and desmopressin. And it's shown that this most of the time shows most long-term success in these patients. But unfortunately, there is also a large group, especially in the adolescents group, that show therapy resistance. And to be honest, if I want to go into detail on therapy resistance, I need an hour on itself to explain all these things. So it's really just in a nutshell that I just want to highlight some things. So the first thing is, of course, important when treatment fails to ask ourselves why does the treatment fails. As already mentioned, there can be common comorbidities that you really should check. For example, sleep apnea, obesity, but also, of course, do not overlook dysfunctional voiding or even anatomical obstructions, for example. And of course, also the lifestyle can have an important impact. For example, fast food late in the night, it can also have a very big influence on your nocturnal urine production. So these things. So I think for the alarm therapy, when it doesn't work, we can also use it, and it's maybe a little bit unconventional and not really written down in any guideline, but you can also use it as a diagnostic tool, short, to, for example, when it's not clear when the teenager is wet during the night, is it early in the night, is it late in the night, you can also try for short time to let them wear the alarm, to have an idea what's the timing of the alarm and when is the time of the voiding, and ask them to also measure the volumes when they wake up from the alarm to see if it's already in a small volume of urine, or if they are having large urine volumes when the alarm goes off. And we also see, of course, and I will talk about that later, when you use an alarm, you can see shift from enuresis to nocturia. And in some really problematic cases, then in the end of the day, many teenagers are already happy that they at least are not wet when they wake up. So then they prefer rather to have nocturia than to have enuresis. So in the very, very resistant, frustrating cases, we also try sometimes to use the alarm therapy to shift enuresis to nocturia if we are with our backs against the wall. And then from a medication point of view, as already mentioned, you have the desmopressin. When it doesn't work, there are many reasons why desmopressin cannot work adequately. So then you need to go to look into detail. Is it a therapy-resistant enuresis or really a therapy-resistant polyuria? And then maybe you should shift your strategy as well. But there are also a lot of other options in medications. Some are studied, some are not well studied, but sometimes tried. There's a lot of literature on that as well. Just to name some, but it's really not a limited list. There are some studies with mirabegron that are promising. Imipramine, the really, really old drug that's used to be prescribed in enuresis, can still have a place in some of our patients. But you also be aware of the possible side effects. It can have cardiotoxicity, so you really need to do an ECG before you start it. For example, reboxetine could be an alternative that should have less side effects than the imipramine. There are also some in study cases that they tried to, for example, give diuretics in the morning to increase your salt excretion during the daytime and have less salt excretion when you're asleep, so less polyuria when you're asleep. Also in the medicine or combinations of these therapies, but they're all very limited data and quite experimental. But in the really therapy-resistant cases, when you don't have much, there are some options that you can try. And that also brings me to some more advanced diagnostic approaches. When you are thinking about using some of these more advanced therapies, it's also good to do it on a rather funded reasons. So then some of these examinations can help you with making decisions. For example, what we sometimes do is a 24 hours urine collection at home, where we ask our adolescents and parents to collect the urine and to have 8 samples in total. So 4 daytime samples, 4 nighttime samples, where we measure sodium excretion and creatinine and potassium and osmolality. And we really try to make a day-night profile to see, for example, if the salt excretion during the nighttime is more than during daytime, which is reversed, which is also kind of disturbed circadian rhythm. And then, for example, you could think about the diet in the evening, and if that doesn't have any effect, then, for example, you could consider using the diuretics in the morning. But that's all based on very limited data, but we have sometimes good results with this in combination with our standard therapies, of course. Then urodynamics is, of course, more invasive. So sometimes we need it, but it can be a barrier for adolescents, for children as well, of course, but definitely for adolescents to go for this test. But if you have obstructive or very bad uroflows, or you think about, for example, anatomic obstruction, then urodynamics can really have a place in these patients as well. And if we think about, for example, neurogenic bladder, then to check, for example, tattered cord, an MRI can also be in place. And really short, but last but not least, sometimes we also want to see if there's, for example, in children where we suspect obstructive sleep apnea, but also other sleep disorders, we sometimes send them to polysomnography to see if we see disturbed sleep as well. So over the past few decades, our ability to cure bedwetting has improved dramatically, luckily for our patients. And we see in our children, an increasing success rate, luckily. So I think the key is that we now better understand enuresis. We better understand that it's multifactorial. We have more tools to try to treat them, so that's really good. But there's still a lot of children and adolescents that are not helped, that have relapse or persisting symptoms. And then, especially in this adolescent group, we should recommend a really multidisciplinary, stepwise approach. And then, if you're lucky to be in a center like we have here in Ghent, that you have a great team where you have close collaboration with the different departments, where you have nephrology, urology working together, but also child psychiatrists or psychologists, good nurse specialists or physiotherapists that really are dedicated to urotherapy in these children and adolescents, and a good imaging specialist in children, then you have a great team to approach these adolescents. And I would add also, as a suggestion, that it could be really interesting to also take up in your team a transition coordinator and to start think about transition if you think about the lifelong LUTS aspects, to guide you with this transition and to be to fill in the gap between the pediatric and the adult ward. Because what we already mentioned, and to make a little bridge, what was already mentioned in the presentation of Mauro, but also in this aspect to lifelong problems, is when we compare enuresis versus nocturia. So they share many similarities, as we all are aware of. They both often have a genetic component, as already mentioned, the children with enuresis and then their parents suffering from nocturia, sometimes even not knowing that they're suffering from nocturia. They're also linked to sleep disorders, but it's not always clear if it's a cause or an effect of our conditions. So the physical and mental health are definitely affected in both conditions, and unfortunately, treatment is not always adequate in also both conditions. The main difference is, of course, that the nocturia, the person wakes up to voids, while enuresis happens without waking. So the bladder-brain communication during sleep is probably the key between the two different conditions, and understanding both conditions and the similarities can really help us, I think, to see enuresis as part of a broader spectrum of nighttime urinary tract disorders. And it definitely also highlights the need for more research into sleep mechanisms and, of course, also genetics. Because you can see also in this rather recent publication where we looked into a group that was treated with alarm therapy. So this was a group, children between 7 and 14 years old that were suffering from enuresis, treated with an alarm. And 1/3 of the children who respond to conditioning with the alarm actually converted their enuresis into nocturia. So it's also important to be aware of that. We also saw that children with high nocturnal urine production before the treatments were also more prone to experience nocturia after treatments. and the children who achieved the dryness seem to improve their nocturnal bladder capacity. So this also appears to be related to a reduction in nocturnal unit production as well. But it's still quite interesting, and it was in a rather small group, around 120 children, but still I really think it would be interesting to dive more into this. And that brings me, of course, to end the circle. And so to go back where we started tonight with our presentation, the concept of lifelong LUTs. So Maud already really clearly explained this concept. But I think for us treating children and adolescents with enuresis, it's really important to take this concept into account when we look at our population. We see really a relationship between enuresis in childhood and development of nocturia later in life. I think it is something that we in the past were not always aware of because we didn't see them back, these children of adolescence, and now we know because we communicate to our adult departments. And the impact of puberty can then be that it might shift the bedwetting to nocturia. So there's a really interesting publications around this topic, and to have an introductory idea about the aspects. It's an interesting editorial from Professor Everett and the whole group, where he states that LUTs really is an interplay between bladder, brain, and kidney function, but really may evolve across a lifetime due to the dysfunctionality of these organs, and can shift, for example, through hormones, but also and also a lot of other aspects can lead to this shift from transition to transition, from phase to phase. So when our adolescents are still suffering from LUTs and or nocturia and or enuresis, it's important to think of transition to adult care in the past, and I think sometimes still our transition from pediatric to adult care is messy and sometimes poorly organized, unfortunately. So despite that we have the numbers that we expect them up to 2-3% maybe of the adolescents still have enuresis, and even some adults, they are for up until now not really good, clear, standardized transition programs, which creates this risk of patients falling into the no man's land between the pediatric department and the adult department. So we think about transition. We also know it, of course, from other more chronic illnesses, that you should start on time. And that means not wait until they're 17, 18 years old, but start around the age of 12 to 14 years old, and start with clear communication to the patients and the family about what to expect, possible relapses, persisting symptoms, possible future lower urinary tract symptoms, and nocturia. So education is an important thing. And as I already mentioned, ideally you have the support of a transition coordinator to help you with that. So there's an interesting paper from Sevastikar Maria and our group, where Maud also contributed to. It's a suggestion how you could set up a transition program and how to look at this population. And they divided the group into 4 subtypes. So the smallest group is the group with refractory enuresis. But it's also the most complex group, needing a really multidisciplinary approach and a good transition protocol. And then you have the other subtypes, with ending with those who, the biggest group, not suffering from enuresis anymore, but having still lower urinary tract symptoms and nocturia as an adult. And also for them, it's important that they know that it's still a condition, that they still can find help for that, or if it relapses, that they find their way to healthcare. So ultimately, transition is not a single event, of course, it's a process. It addresses medical, but also psychosocial and educational needs to ensure the continuity of care and to obtain better long outcomes for these patients. So for now, I would like to end where I started with this comic strip. So the bedwetting profoundly impacts a teenager's life, and that's why research matters to develop new strategies and free more adolescents from this burden. So this, I hope you will all take this into account as a take back to your hospital message. Thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Dosche, for this wonderful presentation. So just a reminder to the participants, if you have any pertinent questions, because we only have like a few minutes left in our webinar, but if you have any questions, you can put them in the chat to everyone and we will go through to them. As people can maybe write down their questions, there was already one question in the private chat, which I will ask to you, both Dr. Dosche and Dr. van den Ende. It was a question concerning if you use physiotherapy and have you looked at the pelvic floor muscle coordination in bedwetters versus non-bedwetters? Do you have any thoughts about that?
I don't know if you want to go first, Lina, or if I go. I can personally say that we, with our research group, still haven't yet. We do believe that there is a very, very important factor of them contributing, or physiotherapy to contribute in this program. But to my opinion, we did not really compare it yet. That I don't know. No.
Well, as we already mentioned, it's multifactorial, and the one child or adolescent with bedwetting can suffer from different reasons why they have the bedwetting than others. And I believe there will be a subgroup of children with bedwetting that also have different pelvic floor coordination, especially when you have no daytime symptoms, but they have persisting bedwetting, then and they it's therapy resistant. Then we start from the beginning, like, are we missing something? Even when there are no or less or just very subtle daytime symptoms, we still then offer, for example, to start again with a uroflowmetry to be sure that we don't miss any pelvic floor dysfunction. I don't know, Bieke, maybe you also have your own opinion as a pelvic floor specialist on this question.
I wasn't thinking that I should needed to answer questions today, but I think you both answered it very well. So there was another question concerning when do you ask for a polysomnography?
Well, one of our basic questions when we approach anuresis is if there are any signs, for example, of snoring, if they have very vivid nighttime terrors, nightmares, or if they're sleepwalking. So that are some, or if they experience any restless legs when they are asleep. So there are some alarm symptoms where we more easily go to polysomnography when we think sleep is involved. And sometimes also in the obese one, but most of them have snoring. But even if they don't have snoring and they have therapy resistance, polyuria, then we also, and they are obese, then we also discuss it with our sleep specialists, and then we sometimes also offer polysomnography. So it's definitely not for all our patients, and also not for all adolescents. It's based on what we have in our screening, in our amnesis, or when we have really therapy resistant cases, when we think that this might have an influence.
Yeah, maybe I can add to that from the more than adult urology perspective. That's also something we do quite similarly, and we tend to stay quite conservatively. We do not start any medication if we have any incentive or any idea that polysomnography could clarify other causal factors for nocturnal polyuria or the persisting nocturia symptoms. So I think, and that's also what in the young adults we still do, as we don't like to prescribe medicine if it's not not necessary, or it can be helped in other ways.
Okay. Thank you. There was also some practical questions which I can answer from Bright. She asked if the recording will be available for ICCS members, and yes, it will be available for ICCS members. So again, if you're not a member, please join. So I think we're almost at the end. So I don't know if there are any specific questions people just want to ask. Maybe one we can still have time for, but I think maybe most of the people already learned a lot from both of you. So I think with this, maybe we can wrap it up. And we really want to thank from our whole ICCS team, Dr. Dosje and Dr. Van den Ende, for your very interesting and insightful topics and your presentations and also your answers. We are very happy that you are here with us. Also for the audience, very thanks for you, all of you, to be here with such a nice number. And we hope that we see you in future webinars from our ICCS. And with this, I think that maybe we can wrap this up and give everybody a good day for the rest of the day. So, bye.